Greetings, I'm Matthew Balti with the Acoustic Neuroma Association. I'd like to welcome everyone to our 2023 ANA Awareness Week. In a moment, we'll hear from Dr. Taha Jan with Vanderbilt Health and his presentation of radiation therapy for vestibular schwannomas, a surgeon's perspective. First, I'd like to handle a few quick items. If you have a question during the presentation and you are watching on Zoom, you can just write that in the Q&A section, which can be found at the bottom of your screen. If you are joining us on Facebook, your questions can be written in the comments section. We may be able to have questions answered as we go through the presentation, but afterwards we will get to as many as we can. Captions are available for this presentation, and you can turn those on at the bottom of your screen as well. This presentation is being recorded, and you'll be able to find this in our webinar library on the ANA website at anausa.org. That is a terrific resource for so many topics you may have an interest in. There's a search option in there so patients can find just what they are looking for. Lastly, a reminder to keep an eye on our social media, this week especially. We're on Facebook, Instagram, and even LinkedIn, and you can learn about the resources available and how you can be more involved with the ANA. The ANA is here to help, so please access those opportunities. And now, Dr. Jan, if you'd like to introduce yourself, we can get started.
Hello, everyone. My name is Taha Jan. Thank you so much for the introduction, Matthew. It's a pleasure to be here. I'm very excited to speak with all of you today, especially during this special week of ANA Awareness Week. So I'll just go ahead and get started, and looking forward to answering everyone's questions. So today I'll be talking about radiotherapy or radiation for vestibular schwannomas from my perspective as a surgeon. This is my main disclosure. I don't have any financial disclosures, but I am a surgeon talking about radiation therapy. So first of all, we'll start with some basics. What is a vestibular schwannoma, also known as an acoustic neuroma? I put this in quotation here because it's a little bit of a misnomer of acoustic and neuroma. I still call it acoustic neuromas, but we'll get to the biology of that shortly. So let's start with the very basics of a little bit of anatomy about the hearing and balance organs before we get into more detail about the tumors. All of these diagrams that I'll show you today are from my mentor, Dr. Rob Jackler, and the illustrator, Chris Graylop, moving through. This is a slice through the human temporal bone. It's known as a coronal slice, so it's a slice this way. The ear has really three parts. There's the external part, which we can all see on the outside, known as the pinna, and it comes all the way down to the eardrum here. The eardrum is attached to the first hearing bone. There's a total of three. These are the smallest bones in the body. This space is known as the middle ear. And then relevant to today's discussion is the inner ear. The inner ear is the hardest bone in the body. It's a bony encapsulated organ, really a set of organs. The total size of this inner ear is about, this whole thing fits within a dime. Within the inner ear, we have the auditory organ known as the cochlea, which is the snail-shaped organ here. And then we have the vestibular apparatus here, or the labyrinth, that really has 5 vestibular organs. And then from here, we have the hearing and balance nerves, or the audiovestibular nerve that goes to the brainstem here. And this canal on the outside, where wax is produced, is known as the external auditory canal. And this canal deep in the skull is known as the internal auditory canal. And the internal auditory canal has not only the audiovestibular or the audiovestibular nerve, but also the facial nerve, which you can see here. And the facial nerve, again, starts out at the brainstem, comes in and makes a loop around the inner ear as a first turn here, and then it makes a second turn before exiting the skull base down here. And other relevant components here are that the audiovestibular nerve, or cranial nerve number 8, these are all numbered, starts out as one main cable here, and by the time it reaches the inner ear, it branches into a cochlear nerve and then 2 vestibular nerves, the superior and inferior vestibular nerve. If we take a slice through the cochlea, we can appreciate some of its anatomy better. We can see that the cochlear nerve comes into the inner ear, and we have these the snail-shaped organ, the cochlea, that is tonotopically organized, meaning high frequencies on one end and low frequencies on the other end. And within the cochlea, we have these specialized mechanosensory cells known as hair cells. These are different from the hairs on your body or on your head. These are really small mechanical receptors. You're born with about 16,000 auditory hair cells on each side. Once you lose them, unfortunately, they do not come back. They're very sensitive. They have a very particular, unique set of genes that are not expressed anywhere else in the body. And what about the vestibular system? So the vestibular system houses 5 different organs on each side, and they're in sync from the left and the right sides. And there are these 3 semicircular canals, the lateral, superior, and horizontal canals, posterior, horizontal, and superior canals. And this is really like the gyroscope of the head. They have these small little patches of hair cells also. These are also mechanically stimulated. Instead of sound, they're stimulated by fluid motion with here. And these 3 are in the X, Y, and Z planes, and they're hooked onto your eye. So they're responsible for what's known as angular acceleration. So you can, look at an object in space, turn your head in different directions, and still know up from down. And then within the vestibular apparatus, we also have the otolith organs. These are organs that are responsible for linear acceleration, the utricle and the saccule. And what that means is, for example, if you're sitting in a car and you hit the gas pedal, you can feel the car moving. That's the horizontal motion. Or if you're in an elevator going up and down, you can feel the elevator going up and down. And that's the saccule. Again, linear motion in the vertical plane. And from here, the inner ear sends signal via the audiovestibular nerve to the brainstem. And the vestibular system is quite complicated. It talks to the cerebellum, it talks to the spine, and it also talks to the eye. So the vestibular system is not just the inner ear, it's really the brain and the position of your joints in space, as well as your vision. Now, let's take a slice through the skull base. Before we were looking like this. Now we're looking at a axial cut this way. And again, we have the same organs here. We have the same anatomy. Here's the external auditory canal from the outside of the ear. Then we have the middle ear, and here's the cochlea, as well as the vestibular apparatus here. And then here's that internal auditory canal. And there's this little bit of a sort of an empty space with spinal fluid before it reaches the brainstem here. And this region is known as the cerebellopontine angle, P for the pons and the CB here for the cerebellum. And vestibular schwannomas really arise in this region. And we talk about the CPA, which the cerebellopontine angle, which is this specific region here. So vestibular schwannomas, acoustic neuromas, are benign 8th cranial nerve sheath tumors. They're not really from the nerve. That's why they're not really neuromas, but schwannomas. And typically they arise from the vestibular nerves, not the acoustic nerve. And they comprise about 80% of all tumors that present in that cerebellopontine angle region that we just pointed out, and approximately 8% of all intracranial tumors. Usually the symptoms are ipsilateral, meaning same side hearing loss, dizziness, imbalance, asymmetric tinnitus, tinnitus on one side, or ringing in the ear on one side. There are a variety of other symptoms, for example, facial numbness, difficulty walking, nausea, headaches, and those are really symptoms of very large tumors. And today, the main focus of the discussion will really be on sporadic vestibular schwannomas, which is about 95% of all vestibular schwannomas. There are patients who have NF2, neurofibromatosis type 2, and similar type syndromes, which is really a different biology and a different discussion. So just keep that in mind as we're going through the rest of the slides here. So what are these nerve sheath tumors? Here's an axon. Here's a nerve with the cell body here, and here's the axon, which is really the cable. It has these dendrites in the axon, and the nerve sheath are these cells known as Schwann cells. And Schwann cells are really like insulating components of the nerve, kind of like a cable with insulation on it, with these little gaps. And what they help do is they allow the signal from the nucleus here, the electrical signal, to basically jump faster. That's their normal function. They're really wrapped intimately around the nerve, and vestibular schwannomas are tumors of the Schwann cells, not of the nerve itself. But as you can see, they're intimately wrapped with the nerve. So the nerve will be if it's affected, the nerve is definitely going to be affected. The function of the nerve is going to be affected as well. So back to our diagram that we saw earlier, and I'm going to flip this the other way now. And again, here's the coronal, the axial cut, meaning this way, to point out the anatomy again, the external auditory canal, the middle ear, the cochlea, the hearing organ, and the vestibular apparatus. And what I really wanted to point out in this diagram is that the 8th cranial nerve starts out as one main cable and it branches. The 2 vestibular branches are not fully shown here, but this is how it branches into these regions. We have other cranial nerves in the region, cranial nerve 5, which provides sensation to the face. And what's not shown here is the lower cranial nerves that go down for swallowing and voice and these things that are a lot lower down here. So let's talk about the growth pattern of these tumors. Usually these tumors start out, the vast majority of them start out within the internal auditory canal here, like this. And the ones that do grow, and we'll get into the details about which ones grow and don't grow, is that some of these will grow and pooch out, and they can cause significant morbidity. Most of them that present look like this, not like this, at least not these days. And so it's important to keep some terminology in mind. And today I'll review some of the literature, some of the latest literature and data on this, because it's important to make our decisions based on data, not just on opinions per se. Here's a cartoon depiction of the internal auditory canal with the facial nerve depicted as a single fiber here. And these tumors, again, most of the time they start out within the internal auditory canal, which you can see here. And this type of tumor is known as intrameatal, intracanalicular, or IAC, or internal auditory canal limited tumor. So you'll see all of these terms, they mean the same thing. Now, if we have this tumor that is pooching out into the cerebellopontine angle, you can see that here. When it grows, it can grow and compress the facial nerve that's depicted here. And this component of the tumor is known as the extrameatal component, or the cerebellopontine angle, or the cisternal component of the tumor. And these are all the same terms. It's important to also, when we're looking at tumor size, that we define, within the internal, within the IAC versus not. Some people measure these tumors only within the cisternal component. Others include this oblong, longer part that goes into the internal auditory canal, which can be a little bit problematic depending on if you're comparing, apples to apples or comparing apples to oranges. So what about size of these tumors at presentation? There are different sizes, and it's important to keep the size in mind. So here is an MRI that shows, that's an axial view, so similar to what we were just looking at the tumor sizes. So it's a cut this way. Here's the cerebellum, the brain. Here's the back of the head. The nose would be up here. These are the maxillary or cheek sinuses. And this is the internal auditory canal right here. And here we can see this is really a tiny tumor, an enhancing mass of the internal auditory canal at the fundus here. And then this would be, kind of a medium-sized tumor that's filling the internal auditory canal and pooching out maybe about a centimeter and a half into the cerebellopontine angle, you can see here. And then really these are large tumors, 3 centimeters or above, that are quite large with some brainstem compression and cerebellum. And this is what we would consider a giant tumor, more than 4 centimeters, that is taking up almost a third of the entire space back here. Today's discussion regarding radiation really is about these first two types of tumors. I would argue that most people, most surgeons at least, will certainly tell you that these are not safe for radiation, and the data actually shows that as well. So what are the treatment options? Treatment options, as most in the audience here know, there's options of observation, radiotherapy, and microsurgery. I don't like to use the word radiosurgery or stereotactic surgery or knife, but you'll see it in my presentation as well. But radiotherapy or radiation therapy does not involve a knife, and it does not involve surgery. And really, modern day treatment is a combination of all three of these, where patients initially are observed and offered either radiotherapy or microsurgery in some combination or different orders. And the factors that influence the choice of treatment really are tumor size, hearing level, and risk of tumor growth. So let's talk about observation first. Today's presentation is not really about surgery, so I'll just give you that as a heads up as well. Some of my colleagues described that a couple of weeks ago, and I'm happy to chat about that in the future as well. But let's talk about what happens during observation. Typical observation involves an MRI within 6 months of the initial MRI. Some people do this at 1 year as well. And really, this MRI is just to demonstrate that the tumor is behaving like a vestibular schwannoma, that is slow growing, if it is growing at all. So we're not looking at 1 millimeter of growth. We're really looking at, is it doubling in size? Is it if it's one of those tiny tumors, or if it's a larger tumor, is it really significantly growing, which typically is defined as greater than 2 millimeters? And to rule out other things. Sometimes there are other things that behave, other tumors of this area that behave differently. And then after that is some sort of serial MRIs, typically yearly, and then every other year or longer, depending on how long the observation has been going on, and obviously the age of the patients and so forth. And then there's the radiotherapy. Modern day radiotherapy involves stereotactic radiation. These are small doses of radiation at different angles focused on a particular place. There are different platforms for this. These are really companies that sell these devices. There's the Gamma Knife, CyberKnife, Linac. But most of the studies for vestibular schwannoma that have come out so far really don't show, I would say, a major benefit of one over the other. And we'll get into some of the details of that shortly. And this is the only surgery slide that I have. Surgery involves multiple different approaches: the translabyrinthine, which is through the ear, the retrosigmoid behind the ear, or the middle fossa above the ear. So how common are vestibular schwannomas? So to define, and this is important to look at so we can get an idea of what these are doing and how many of them there are. To define this, we need to know the prevalence, and we need to know the definition of prevalence. Prevalence is a percentage of a population or number in a population that's ever been diagnosed with this disease at a particular specific date. So the prevalence of vestibular schwannomas, both in Europe and the United States, that have been described, approximately 1 in 2,000 adults, or about 1 in 500 in those that are 70 years and older. So not very common, but not uncommon either. This is a study from Denmark, which has one of the largest cohorts of patients. They have a single center, so everybody, small country, nationalized healthcare system where everyone goes to the one place for their acoustic neuroma care. And this study's been running, their registry has been going back to the 1970s. So we have a longitudinal look at things for a very long time. And what you can see here on the y-axis, we have the percent of tumors, so the ratio of tumors, and here are the different time points. And the color coding is by the size of the tumor. So the green is intracanalicular, or those that are very small within the internal auditory canal, and black is really those giant tumors that I showed you. And what you can notice is that over time, as imaging technology has advanced and we're scanning more people for other symptoms and symptoms of hearing loss and asymmetry and such, we're discovering a lot more smaller tumors, and those very large tumors are a much smaller percentage. So about half of the tumors are within the internal auditory canal. And then looking at how we're treating these, how we're treating vestibular schwannomas nowadays in the pre-MRI era and in the current modern day therapies, that we're finding that back in the, before MRIs, we would treat a lot more patients and observe a lot of less of these patients. And now we're observing more patients, but we're even treating more because we're seeing a lot more of them. So despite a shift towards the initial observation, the overall treatment prevalence that includes radiotherapy or surgery per population has actually increased. So what happens if you watch these tumors for a while? So again, looking at the Denmark study where they have 40-year prospective data from an unselected national cohort, and I'll share with you the Vanderbilt experience with observation as well, is that the main takeaways from this study was that approximately 75% of those tumors that present in the internal auditory canal do not grow beyond the internal auditory canal after 10 years from diagnosis. So they can grow a little bit within the internal auditory canal, but not pooch out into the cistern or towards the brainstem. And about 60% of the tumors that present already out of the canal do not grow 10 years after diagnosis. And that growth may occur during the first 12 years of observation. And initially, growth is more likely during the first 5 years than beyond that. And this is very similar to what we have here at Vanderbilt. We've observed over 500 patients. This is a study that we put out back in 2016 that shows that, that if you start out, and this is broken down by tumor size, and these charts are known as Kaplan-Meier survival curves, and the survival is not really whether the person's living or not, is mainly what the intervention was. So over here is the proportion of tumors without growth, or on the y-axis here, or before intervention, and on the x-axis here we have time, typically in months or years. And so I'll be showing quite a few of these graphs. So we can see that if you start out with a small tumor in green, you're less likely to grow or have an intervention over time than if you start out with a tumor that's greater than 2 centimeters. So these are more likely to grow and that you'll need some sort of intervention. So what about hearing during observation? So again, looking at some of the studies out of Denmark, and I'll show you some here from the United States as well, that They looked at over 1,000 patients, observation of approximately 5 years, anywhere from 1 year to 29 years. About 160 patients, roughly 159, had 100% speech recognition at start, and 87% of them had greater than 70% word recognition after that observation period. And then on the other end of the spectrum, about 300, just over 300 patients with less than 50% word recognition, 2% had good hearing at the final evaluation. So the main takeaways here is that if you start out with good hearing, you'll likely end up with serviceable and okay hearing. If you start out with poor hearing, you'll likely lose the remaining hearing. And this is, again, the same type of Kaplan-Meier curve that I just showed you, that shows that if you start out at really good hearing, you'll end up with pretty good hearing after about a 10-year observation period. But if you start out lower, you're more likely to have decline in hearing. And there was even a recent study just last year, metadata looking at multiple studies, thousands of patients, that those that had serviceable hearing at the beginning, that within 3 years, 75% kept their hearing serviceable. And after 10 years, about 40% or so kept their serviceable hearing. And these are, studies vary, so there's some variation from this. So now let's talk about radiation. So what is radiation? Radiation is basically a focused beam of energy through particles, usually photons, delivered to a precise location. Medical radiation involves ionizing radiation. This is radiation that breaks and causes damage to DNA, so cells that are dividing don't do as well. And stereotactic radiation, as I mentioned, is the modern day therapy for this. And radiation is kind of like light, but here's the visible spectrum here, and radiation therapy is out here, way out here. There are different types of radiation, as we mentioned. One of the common sources of radiation for vestibular schwannomas is known as the gamma knife. This is really a multi-source device, so there are multiple beams here that come and uses cobalt-60 gamma unit. And then there's the single source linear accelerator based, such as the CyberKnife or LINAC, where it's really a linear accelerator that moves with a robotic arm that moves around the patient to deliver the radiation. And the radiation comes in at different angles to that specific spot. This is the same thing, but it has multiple sources. And the frame that's used whenever there's radiation delivered, the head needs to stay still and at the same location every time. And the gamma knife uses a head frame like this, where it involves putting some frames directly on the skull, very tiny incisions here. And the CyberKnife involves a mask that is custom made for you, that you wear for the session or multiple sessions. So how much radiation is used? Typically 12 gray in one dose, or 6 gray over 3 doses. The gamma knife, typically it's 1 dose. With the CyberKnife, typically 3 doses. It has been shown that 6 times 3 does not equal 12, but it's 6 over 3 separate, and it's really 12 gray biological, but a total of 18 gray. This is a little bit less harsh on the cochlea than the 12 gray, at least in some studies. So this is what the radiation therapist does. In some places, the surgeons are involved in this as well, and in a lot of places. And so here you can see this is again an MRI axial view. So we're looking this way. The eyeballs are out here. The back of the head is here. Here's the internal auditory canal on the normal side. Here's the tumor, and you can see that the focused beam of radiation is going to be right on the tumor. Here's the cochlea, and here's the vestibule and the vestibular apparatus, the rest of it here. Now, the most radiation will be focused on this area, but surrounding tissues, including some of the brainstem here and some of the cochlea and the vestibule, will also receive a dose of radiation. So it really depends on the size of the tumor and where it's located. So if you have a tiny tumor here at the fundus close to the cochlea and the vestibule, then the cochlea will receive some radiation. Whereas if you have a tiny tumor over here, less likely they'll receive the same dose of radiation. And that's important when we're talking about hearing and balance in these tumors that get radiated. So benefits of radiation: it's pretty well tolerated, right? It's easy to get, little to no immediate side effects initially. Short recovery time. Typically, you can drive yourself and drive yourself home. Short treatment duration. You avoid surgery, and tumor control rates are somewhere between 90 to 95%. This is highly variable depending on the size of the tumor, and tumor control means that the tumor is not growing. And the risks of radiation, the tumor Control rate I'll list here again because that's a risk and it's also a benefit. Again, it depends on your tumor size, the lack of definitive diagnosis because we don't have a piece of the tissue, need for continued surveillance, and some persistent worsening vertigo that typically is temporary, not always. There are some rare side effects of radiation, including neuropathies of the trigeminal nerve and nervus intermedius. Trigeminal nerve, if you have a bigger tumor that is affecting the fifth cranial nerve. Facial spasms are not uncommon. This is usually temporary and goes away. Again, for larger tumors, you can get necrosis of the brain or a vasculopathy-induced worsening tinnitus or headaches. Hydrocephalus, this again for very large tumors, which I do not recommend radiation for, except in very exceptional cases. Potential for malignant change. This is really very rare, but there are case reports of malignancy following radiation and gate disturbances. So what about the outcomes of radiation? So how do we measure the outcomes? Radiation outcomes, we're looking at tumor control, and tumor control is whether the tumor is growing or not. And so if you don't know the tumor is growing initially, then if we radiate every tumor that walks in with a single MRI, then we can pat ourselves on the back and say, hey, look, the tumor didn't grow. But the reason I talked about observation is that, about half these tumors don't grow initially. And so here's, again, a Kaplan-Meier curve. This is a study out of Stanford, and we can see that tumor control rate, so 100% to 0 here. And this is the time period looking at approximately 10 years and really over 10 years. And in total, you can see that the tumor control rate is roughly about 87 to 90% here. Now, if there was no SRS stands for stereotactic radiosurgery here. No pre-SRS growth, meaning they didn't know if the tumor was growing or not. You can see that the control rate's around 90%. And if there was growth, the control rate is a little bit lower. And this is really looking at aggregate. And now we're breaking it down into different tumor sizes. Same type of graph. Here's time on the x-axis here, and y-axis shows growth rate. And we can see that with small tumors, right, intracannulicular within the internal auditory canal, pretty good control rate, 80, 90%, maybe above 90%. And then with larger tumors that are larger than 2 centimeters, that falls off. And this is looking at their entire cohort of over 500 patients. So what about hearing following radiation? And this is looking at all of these same patients, 579 patients that either maintained or had better hearing. And you can see that hearing declines over time with radiation as well. But the magnitude of hearing decline is a little bit more than if these tumors were just observed for those that can undergo observation. And I'll get into greater detail, but really it has to do with the cochlea receiving radiation. And that's been shown even in some of the latest studies using proton beam for vestibular schwannomas. So this is a really nice curve looking at patients who present with 100% word recognition. So 100% word recognition, and if they were radiated, this is 139 tumors, about half of them, you can see that about half of them at 10 years end up with worse hearing. Significantly worse hearing. And it's important to compare this to if you did nothing for these same tumors. Again, we're talking about small and medium-sized tumors, that the rate of decline in a patient who has 100% word recognition is worse if you've received radiation versus observation. And that makes biological sense if the cochlea receives a dose of radiation. So what will radiation do? It will prevent the tumor from growing, again, depending on the size, whether it's 87%, 90%, 95%, 98%. It really depends on the size and whether if the tumor was growing to begin with or not. Obviously, all tumors grow to a certain size, right? That's how we are able to discover them, but we're looking at the rate and the curve of these tumors over time. What radiation will not do is it will not make the tumor go away. It will not get rid of tinnitus or preserve hearing, as I demonstrated just earlier, and it will not get rid of vertigo. Vertigo typically gets better with time. This is one of the latest studies that just came out a couple of weeks ago, earlier in August 1st, I think. This is out of the Journal of American Medical Association. This is the European group. And this here, what they did was they did a clinical trial where they randomized patients. So they took approximately 100 patients and they randomized them either to observation or to upfront radiosurgery. This diagram here shows the tumor volume that they measured. And on the left side is the patients who received radiation. On the right side is the patients who had waited and gotten a repeat scan. And again, randomization. So no patient choice, you just get randomized. A couple of patients dropped out of the upfront radiosurgery, but what you can see that over a 4-year period, there are 50 patients in each arm, so not very large, but also not very small, 50 patients in each arm, that you can see that what radiation will do is for small and medium sized vestibular schwannomas, it will help reduce the tumor volume over time. But the patients who were only observed, about half of the tumors did not change at 4-year follow-up. So this tells us two things really, that radiation helps shrink some tumors, doesn't get rid of them, but it shrinks some of them. But that patients who otherwise would have been observed, half of these patients got radiation where, at 4 years, there would have been no change in the tumor size. So it's really important to look at radiation versus observation in this cohort. So in conclusion, I'm at about 30 minutes or so now. Factors that really influence the choice of treatment is tumor size, the hearing level, the risk of tumor growth, age and longevity of the patient, and those two are not always correlated. There are some who are 60-year-olds who are very, very medically ill. There are others who are, the same age, but have much longer longevity. And overall health of the patient. Radiation therapy is a good treatment option for many, but certainly not all. For large tumors, radiation is a good adjuvant tool, and I didn't touch upon that in detail. But for some of those larger tumors, I typically advocate resection of the tumor and leaving just a little rind behind, concession to cranial nerves, specifically the facial nerve, and then radiating what's left over if it shows growth over time. For large tumors, radiation is good adjuvant tool. Do not radiate a tumor if it's not been shown to grow on serial imaging. That's pretty clear. And caution of radiation, great caution, I should say, if there's a tumor that's greater than 2 centimeters within the cerebellopontine angle, because really those tumors can cause quite a bit of edema. And particularly if you're a younger patient and in 40s and 50s, we've got a lot more years to go, that's going to cause a lot more trouble down the line. We can certainly do surgery after radiation as well. Some of the complication rates are slightly higher in those patients and with some of the other risks. So in general, tumor control and preservation of cranial nerve function really take precedent is my management philosophy. And this is sort of mostly what we do at Vanderbilt. This is from our 2016 diagram, that if you come in with an MRI, if it's greater than 2 centimeters and you've got brainstem compression, we recommend some sort of intervention. If it's less, we would recommend some observation period before intervening. This is our group. We have a large group now. Dr. Haynes is our division chief. There's 7 neurotologists and 2 fantastic nurse practitioners. And this is my contact information. I'm happy to answer any questions now.
Great. Fantastic presentation, Dr. Jan. Thank you so much for all the information and all those really informative graphs. Before we get all the way into questions, I did want to mention you talked about Dr. Maroney, Dr. Perkins, and Dr. Tofik, who joined us a couple weeks ago for ANAwareness Week, talking about the surgery side of things. Remember, you can check out all of our previous webinars at anausa.org, and this one will be recorded and there as well. But with that, let's go ahead and get into a few of the questions that we had. Can you clarify how big of a tumor may be too big to consider radiation?
Yeah, I think, in my opinion, anything over 2 centimeters within that cerebellopontine angle, I think is too big. Now, again, there are some exceptions to the rule. There are some studies actually looking at tumors that are greater than 3 centimeters where they report 75 to 80% control rate. But really, we have to look at are you a 75-year-old ill patient who has multiple medical comorbidities, or are you somebody who's younger and doesn't have as many medical comorbidities? So my limit is usually around 2 centimeters within, pooching out of the canal is when I would say, okay, we're right at that threshold that we're going to cause some issues down the road with acute edema. Does that answer the question?
Yes, it does. And we recognize that, there are a lot of factors to it as well.
Of course.
Another question about tumor size and specifically the hearing, you showed us about radiation versus observation, but this question was, if I choose radiation over surgery, do I have a better chance at retaining my hearing?
Yeah, great question. It really depends on the tumor size, right? So if you have a tiny tumor within the internal auditory canal and you're choosing surgery, I would certainly recommend that you see an experienced surgeon who is familiar with approaches for hearing preservation. That hearing preservation rate varies, right? Depends on, again, what you start with versus, so what you start with is the most important factor for both surgery and observation. And then likewise for radiation, it depends on really where the tumor is located. We know that the cochlea, if it receives any dose of radiation, then it will take a hit, whether that's early on or later on. And so, and if the tumor, if you're looking at hearing preservation, I think an experienced hand surgery would be the way to go versus observation. And there's an argument to both of those. I personally would observe that tumor if you have really good hearing to the start, because as I showed you that 75% of those patients will end up with really good at the 10-year mark. But again, in experienced hands with the middle fossa approach, you can also go with a hearing preservation rate, but it's also possible that you lose all of your hearing right after surgery.
Got it. We also had a couple questions come in about regrowth and swelling. Someone was asking, is it true that my tumor will swell but not necessarily grow after radiation?
Yes, that's exactly that is true. It's pseudo progression of tumors. So typically when during radiation, you're basically frying the tumor and it will swell a little bit. And this is one of the reasons why large tumors, I recommend radiating, because if it caught during that swelling period, it can cause some compression of the brainstem and lead to some other complications. But yes, the tumor will grow, particularly within the first 6 to 12 months. And so we'll see a little bit of growth of the tumor. So it'll swell a little bit before it starts to shrink back to its original size. And usually that phase of that period is around 18 months in most places. So, usually get a 6-month or 9-month MRI and then a year after that. And that's really when the symptoms, the side effects of radiation come in. It's not right when you're getting the radiation, but during that swelling phase is, typically common to get some headaches, vertigo, potentially hearing loss. And so if you have a much larger tumor and they're swelling on the brainstem, that's when we can get some of those other complications with radiation on the larger tumors.
Great. Thanks for that clarification. The other question was talking about the timeline for it, so you answered that as well. You talked a little bit about the short-term side effects that you can find with radiation. Someone was wanting to know, do you find fatigue to be a lingering side effect of radiation treatment?
Yeah, certainly fatigue can be a lingering side effect. Fatigue is kind of can be multifactorial, obviously, right? But it's not uncommon to have some fatigue and really, again, I think with the vestibular system being affected and that comes along during that 18-month time period, really about 6 to 9 months after the radiation is when you'll start feeling a little bit more tired. Particularly patients who have history of migraines and other conditions will feel that a little bit more than others.
Moving on a little bit towards the type of different radiations that people see, what deciding factors do you see patients making when deciding between fractionated and single dose radiation?
Yeah, I think part of it is well, there's a few practical things, right? What's available, right? At the institution that you go to, do they have availability of fractionated versus single or not? Typically, the non-fractionated one is the gamma knife with the part that you get the head frame on directly. Although some of the more modern ones that are multi-source, like for the LINAC, for example, you can come back multiple times. But it really depends on the institution's experience with that. The data shows that if you have fractionated, meaning getting 2 or 3 doses, typically 3 doses over 3 time periods, that has slightly better hearing outcomes than those that don't. But again, it depends on the tumor size and it depends on how much hearing you have to keep.
We have someone who actually came across a medical article which mentioned the release of a toxin by a non-growing vestibular schwannoma that impacts the cochlea, causing hearing decline. The conclusion of the authors is that this finding explains how non-growing vestibular schwannoma tumors can cause a decline in hearing. Can you comment on this? Are you seeing anything like this?
Yeah, so that's a great question. I'm not sure what exact article they're referring to, but I used to work in a lab where we're looking at factors released from vestibular schwannomas. So the size of a vestibular schwannoma does not always correlate with the degree of hearing loss. So the thought is that there's some other biology. Now, we're not talking about, one of those super giant tumors that we were mentioning that can be life-threatening. But if there are small tumors that have really poor hearing, and there are small tumors that have really good hearing. And the question is, why is that? And one of the theories is that these tumors are secreting factors that are affecting the biology of the inner ear. And that to a degree that is true. We know that if we look at the cochlea in vestibular schwannoma patients and looking really at the proteins that are expressed, it's different if you have a schwannoma versus not. But the question is out there, what can we do about this to prevent hearing loss in patients who have vestibular schwannomas? There are some companies that are working on things to affect this. For example, we know that certain chemotherapies for patients with NF2 can actually improve hearing in a select number of patients and control the tumor size, right? That would be the magic treatment. There's medication known as Avastin or VEGF inhibitors. So that's one component of it, is that there's some sort of inflammatory process. Really, the thing that I would love to see that many are working on now is there a way to predict that ahead of time, right? Can we predict that from an MRI? Can we predict that from, for example, sampling some spinal fluid, if you have that small tumor, is it going to grow or not? Is it going to affect your hearing or not? We're not quite there yet, but I suspect in the future we may be. And the other thing that's been mentioned, there's been some studies, for example, looking at aspirin and whether if you take aspirin, which is an anti-inflammatory, if it prevents the tumors from growing or perhaps affects your hearing. And there's conflicting reports of that. Some of the studies coming out of the Mass Eye and Ear initially showed that yes, aspirin affects this. Some of the studies coming out of us, we looked at our large cohort of vestibular schwannoma patients, and there was no change in patients that had growing and non-growing tumors. And really the way to answer that question is to randomize patients, right? Patient comes in, you put half of them on aspirin and half of them not, or whatever this toxin is, if we can find an inhibitor for it. But those are still unanswered questions, but very interesting ones.
Right.
And ripe for scientific study, I might add. Yeah. As a certain scientist, I have to advocate for those.
Absolutely. Someone mentions that they have a 7-millimeter tumor, which seemingly took their hearing overnight. Is that possible?
That is certainly possible. You can get sudden hearing loss with vestibular schwannoma. So about 3%, roughly, depending on what study you look at, of vestibular schwannomas present with sudden hearing loss. Patient comes in, they lose their hearing. We get a scan on them and they have a tumor. But you can have an existing tumor that's small. 7 millimeters is a very small tumor, and it can all of a sudden drop your hearing. That can certainly happen. I always advise my patients that have small tumors that we're observing, if that ever happens, let us know right away. We can give some steroids to potentially kick things back up, at least give it a chance, basically. But that certainly can happen, and that falls within that percentages that we talked about during the presentation, that if you present with good hearing or serviceable hearing, at 10 years, 40% of the patients roughly get to keep serviceable hearing, but that doesn't mean all, right? And at 3-year mark, it's around 75%. So there's 25% that don't, there's 75% that do.
Circling back to fatigue, which you talked about with radiation, this patient was wanting to know, is fatigue more or less of an issue with radiation versus surgery?
Yeah, great question. I think, the way I look at radiation versus surgery is a little bit different. With radiation, you're kind of prolonging some of those side effects and they're delayed. With surgery, you take it up front, right? So, recovery from surgery is 6 to 8 weeks in most patients, and you get the most fatigue, really horrible fatigue right after, but then you recover a little bit faster afterwards. So it really depends on the time frame, right? And so that's the way I think about surgery. You take all the side effects and things up front, and then you're done with them for the most part. And then radiation, it's a little bit later and it's more prolonged at a milder component. And usually things like if your balance system is not good, you're going to be more fatigued, right? So if you have some vertigo and headaches, it takes a little bit longer for the body to adjust.
This patient is wondering, if you have a subtotal surgery and have the remaining tumor radiated, are there additional issues with that radiation?
Yeah, great question. So it depends on how much tumor was left behind. So when we talk about subtotal resection, there are two categories. There's one called near total resection, meaning a very small, greater than 95% of the tumor and by volume was removed, versus leaving a subtotal resection where you take a big chunk of it out, but there's still a generous chunk remaining. And so those are different categories. And so the patients who have a significant portion of tumor remaining, then I would advocate that radiation is certainly an option after that, because that tumor is more likely to grow. And typically we know if you leave more tumor behind within the internal auditory canal, that your chances of regrowth after a resection are higher, versus if you're leaving a small amount. Now, if you leave a small amount and it's not growing, I would just watch it. That would be my personal preference. Again, there are many factors beyond that. But radiating a smaller volume is more likely to work than radiating a larger volume, and that's what really the data shows as well. Hope that answers the question.
Yeah, absolutely. Well, Dr. Jan, thank you so much for your presentation. That's all the time we have for questions, but thank you so much for your time today and for your partnership and Vanderbilt Health's partnership with us as well. You guys partner with the ANA in so many ways, and we are so grateful for that. Thank you so much.
Thank you so much. Really a pleasure talking with you and everyone else in the audience. And thank you so much for the questions and the opportunity for this presentation. Take care. Have a good one. Bye-bye.
Thank you again, everyone, for joining us. You can check out this webinar and more on ANAUSA.org. Have a great day.